Just maybe you can speak out loud. It's okay. Unanimous answers. I don't have your roll number. I won't give marks to you. Just speak out loud. Anything. Any guesses? Breast. Okay. One answer is breast. Any other answers? Let me show you the other part. See, as I told you, it is very important. Perspective is very important. Okay. You didn't tell me to show the other side of the specimen. Now what do you think? Oh, is it still difficult? Oh, it's foot. Right. Okay. So if you just see this, it is very difficult to make out. When you see the other side, then you can make out it's a foot with a growth at the lateral malleolus. So what could this be? Maybe a squamous cell carcinoma? A growth? What else is the reason why the foot has been activated for the growth? Gangrene, okay, but do you think this part is because of the gangrene, or is this gangrene really? No, I don't see any blackish discoloration, though this specimen would be like 3 or 4 years old. It has not even got black, right? So this is a specimen of foot, maybe, right, with a growth at the lateral malleolus, which probably could be squamous cell. So perspective, guys, is very important. If you see things from one side, things like this can happen, right? When you start seeing it, so you take your time when a specimen is given to you. Okay, आगे से देखो, पीछे से देखो, side से देखो, and let the examiner know you are thinking, even though you are not, but still let them know. Okay. Antemortem, postmortem. The first specimen. What do you think? What is the specimen? It is specimen. Uterus with thyroid, very well. Right? Could it be postmortem? Could it be postmortem? It can be. Right? But I don't think so. FMT, forensic people are just removing uterus. Right? So it probably could be an antemortem specimen. The other one, again, it speaks for itself. It's postmortem, right? No questions asked. Identify the surgeon. What is that first specimen? Appendix. Okay, so we start left and right. So left specimen is appendix, which is the probable surgery that would have undertaken. Appendectomy. Yes. And why do you say again this is appendix and not fallopian tube? Tubular blinded, right? It is slightly edematous, no fibrillase or anything which are seen, right? The other one? Thyroid, very good. Which surgery? Show of hands for total. Subtotal? Yeah? Seems more like subtotal, right? You can even see a ligature here at this part at the top of the right side of the loop, right? And there's nothing on the left side. So probably the superior thyroid artery has been preserved and a part of the thyroid gland must have been left. Can you identify the pathology?
Multinodular goiter.
Multinodular goiter. For multinodular goiter, would you do a subtotal thyroidectomy? Yes? No, maybe. Not really. And multinodular, I'll be showing that specimen to you. Those are very large nodules that you can see. These are very small nodules. Okay? Probably it could be a solitary thyroid nodule. Okay? Where you want to rule out whether it is follicular carcinoma or not. Right? Because solitary thyroid nodules are known to cause follicular. Identify the paths. Left side. Okay, they both are they the same specimen? Yes, they are the same specimen. What is the part? Kidney? Kidney, you guys think this is kidney? Yes, okay. So, the decision goes in the house, it's kidney. Is it, can you see the cortex, the medulla, the setosal surface? It is cut open, right? And can you see something on the upper pole of the kidney? Yeah. So there is a growth, there is a tumor there. Tumors in the upper pole of the kidney. And this probably seems to be an nephrectomy specimen. What are you thinking? Renal cells, right? So identify the parts of the specimen. We have identified the pathology. Okay. One more. What do you think? Uterus, is it? Oh, very good. Testes. Why do you say testes? Yeah, I purposely kept it like this. Okay, I have rotated the the image to confuse it, right? So yes, as he rightly said, we can see the cord here, okay, and the testis which is cut open. And do you see any seminiferous tubules or anything, any normal histology of testis inside? No, there is a big tumor there. What do you think? There is a white tumor, right? Sure. Let us start describing this. Let us go row wise. Okay. This row. Can you identify the specimen? There will be certain questions that will be asked on it. What do you think? First, the approach. Let us stick to the approach. What is this? Liver? Liver? It is a slice of the liver, right? What do you see in it? Cut end is that the cut end can be seen very well. Okay, and there are multiple cavities that you can see in it. And the cavity, do you describe the cavity? Can you describe the cavity? You can see the wall of the cavity appears ragged, right? And there is necrotic material also which can be seen. So most probably this is a amoebic liver abscess. Okay, so the questions, the first question that I would like to ask on that question, how to differentiate between amoebic and pyogenic. First row, please, guys, come on, quickly. Why was it amoebic and not pyogenic? Or in a fresh specimen, you would have known. What are the pathological features of amoebic liver abscess versus pyogenic? Anchovy sauce? Yes, very well. Pyogenic will have pus. Okay, there are multiple cavities. It can be pyogenic also, but again, it is on the most dependent part, the seventh lobe. It is the extreme most. Okay, so that is how you differentiate between amoebic and pyogenic. What about how you differentiate clinically both the things, both the pathologies? Amoebic versus pyogenic. Come on. Fever with chills will be present in pyogenic. Amoebic would just present with maybe pain and lump on the right side of the hypochondrium or on the right hypochondrium, right? And anything else? Sorry? History of diarrhea. Very good. History of diarrhea for amoebic liver. Okay. How will you manage? Amoebic? Aspiration? Will you aspirate for all amoebic liver abscess? No. Sorry? Pigtail or aspiration depending on what is the size of the abscess. And what about pyogenic? All the pyogenic abscess, liver abscesses, small, large, would require aspiration? No, we will start with medical management. Right? Next question. Second row, please. Okay, gallstones. So, see, this is directly going to the pathology. First, identify the organ. There are not stones, only stones. There is something which is holding the stones. What is it? The gallbladder, right? Gallbladder, and the gallbladder appears thickened. Yes, and there are gallstones which cannot be missed. So what do you think? What is the pathology or the clinical diagnosis? Cholelithiasis with possibility of cholecystectomy. Probably cholecystectomy. Can't say gallbladder is thickened. That could be the cause, right? The questions, the usual questions are different types of gallstones. This row. Sorry? Cholesterol stones, pigment stones, black and brown causes, cholesterol stone causes, factors responsible for formation of gallstones. Dyslipidemia, missil formation, we know there is a fixed ratio 20:1. Okay. What is the cutoff range beyond which the stone starts forming? MCQ 1. 13:1, right? So that beyond which that is the ratio. 1:20 is the normal ratio which will help the cholesterol to be in the liquid form, right? You need 20 molecules of bile to keep, or bile acids to keep 1 molecule of cholesterol in the liquid state. Okay, if that ratio drops down to 13:1, the stones start forming. Black stones, etiology of black stones, hemolysis, right? And brown stones, infection. Brown stones can be even primary CVD stones, right? Sequelae of acute cholecystitis. Sequelae of acute cholecystitis. Come on, fast. Rapid fire वाले question. Gallstone ileus थोड़ा आगे चलेगा, ठीक है?
Empyema gallbladder perforation.
हाँ, mucocele, pyocele, gallbladder perforation, right? Cholecystoduodenal fistula causing gallstonitis, and
Gallstone pancreatitis.
Gallstone pancreatitis. What else? A rare but a very important malignancy, and malignancy as well, right? What is the dictum? It says that not all gallbladder stones will cause cancer, but all GP cancer will have these stones, right? Though the incidence is just 0.5%, gallstones causing GP cancer. Next, what do you think? What tricky? This row. Penectomy or penile specimen. Complete, total, partial, right? What can you see here? Proliferative growth, which can be seen at the glans venous. You can see the coronal sulcus. You can see the prepusal skin, which is retracted. Got retracted maybe because of the tumor, which is adherent to it, which is indurated, right? The growth is cauliflower type. On the cut surface, you can see the growth going up to the corpora cavernosa. Okay, if this would have been a good specimen, you could see the urethra, which is the stomach, right? So this most probably, what is the diagnosis?
Squamous cell carcinoma.
Squamous cell carcinoma. Squamous cell carcinoma it is. Okay, very well. The questions: pre-malignant conditions of carcinoma, please.
Bowen's disease.
Bowen's disease.
Erythroplasia.
Common one. Right.
Actinic keratosis.
Sorry.
Actinic keratosis.
Actinic keratosis. Okay, common one. That you see day in day out in your OPD. Phimosis. BXO. Chronic perineupostitis. Okay, these are the common things. Okay, whenever you are answering in vivas, keep your donkeys first. Then go to your zebras. ठीक है? Common चीजें पहले बताओ. Uncommon बाद. Right? Pre-malignant conditions. Spread.
Lymphatic spread.
Lymphatic. Okay. Direct spread possible? Yes. But what is that? What prevents direct spread? What is that protective layer around the penis or the muscles? Bugs fascia. Very good. Bugs fascia is something which prevents direct spread, but when it happens, it can go and involve the skin. And does it involve the urethra, or the involvement of urethra changes the TNM staging? Yes, no, maybe.
Yes.
No. Okay, T3, T4. T3 is corpora, cavernosa, T4 corpus, spongios, T2, T3, right? T2, T3. T2 corpora cavern होता, T3 corpus spongiosum plus or minus urethra. Okay, urethral involvement does not change the T stage. Very good. Okay. Then lymphatic spread. What is the lymphatic? For that we need to know the lymphatics. Drainage of penis. Okay, so let's take both these questions together.
First degree superficial involvement.
Right, but let us first discuss the lymphatic drainage of penis. Skin. Where does skin go? Skin or prepuce? It goes to the which lymph node? Which?
Superficial.
Superficial inguinal lymph node. The skin is drained into superficial inguinal lymph nodes. Glans and corpora deep. Okay, and then because of this, there is a crossover, right? So if till the time your skin is involved, you can get away by doing a unilateral inguinal dissection. Okay, when it starts involving the corpus or corpora, the muscles, you might have to do pilot. Okay, but let me give you a scenario. There is a patient, not socio-economically weak. Okay, comes to you with a growth, and he has growth over the glands, and he has inguinal lymph nodes as well. What will you do? Will you directly take him, do a partial penectomy if you have the resection margin? What is the resection margin required?
2 plus 1 centimeter.
Sorry?
1 to 2 centimeters.
2 centimeter?
2 plus.
Okay, yes. What about the lymph nodes? Will you do inguinal lymph node dissection for this patient? Yes, right away. Show of hands for yes.
Depends, it can be infected.
So what will you do? The
Centimeter
patient has come to
biopsy.
you. You can't say this to the patient. Okay, it will depend. What is the next thing you'll do?
Sentinel is not.
Sampling. Will that be your first thing, or you give antibiotics? You give antibiotics. You wait for the infection to settle. If at all, if it is infection, it will settle. After 14 days, you review and do a FNSC. Okay, if it is positive, then you can go ahead by doing a treatment. Okay, very good.